Okay, let's get started. If everybody's able, if you're all able to hear me, let me know. Okay. Hi, I'm Catherine Cates Wessel. I'm the Chief Executive Officer for the American Academy of Addiction Psychiatry, and I'm the Principal Investigator for the SAMHSA funded grant Opioid Response Network. I want to thank you all for joining us. This is a great opportunity for this collaborative effort, and we have a star lineup here with members of the American Academy of Addiction Psychiatry. So you're going to hear more from them, but I wanted to have a few moments just to tell you a little bit about Opioid Response Network grant. So help is here. Everybody's struggling with getting the resources and help they need, and we all know there are not enough addiction psychiatrists out there. We wish we had more, but we don't. While we can, we're going to optimize access to them and learning from them. But the Opioid Response Network is a SAMHSA funded grant. It's free to anyone. Free. Don't forget that. And it has people like the experts we have online as consultants and others that are placed in local communities. So if you have a question or a need beyond today's conversation, or it stimulates something where you want to have more interaction with someone to ask questions, really around training and education, go to opioidresponsenetwork.org and submit a request. So who are addiction psychiatrists? A lot of people, I've been in the field a long time, a lot of people don't even know there are addiction psychiatrists. It's a very small number, but a unique group with unique skill set. Addiction psychiatrists are all physicians. They've all completed a fellowship in addition to be a general psychiatrist. We also have several that are boarded in several other disciplines, such as Dr. Gray and Dr. Vito and some of the others that are also specialists in working with children or adolescents. So that's a big part of what we have today, are people that are experts in dealing with substance use disorders and coupled with co-occurring psychiatric disorders. Because we often know that people with a substance use problem or a mental health problem also have the other co-occurring. So they provide treatment, they work in treatment programs, they work in hospitals, universities, they do research, they train, they publish. So they're really, I think, the dream team and the people that we most need to have in dealing with substance use disorder. Now, that doesn't mean that others aren't in the field are not needed. We need counselors, we need social workers, we need psychologists, we need people in recovery having the lived experience. It is a multi-pronged approach in dealing with a very complicated disorder. So I'm going to get off now, and I'm going to turn it over to the experts. And Dr. Jose Vito, he is one of our superstars joining us today. He's at NYU. He's going to be the moderator and kind of overseeing things. Kevin Gray, also a board member at AAAP, is a child psychiatrist and addiction specialist, and Dr. Filho and Dr. Vel and Dr. Patel. So I'm going to turn it over to Jose, but again, just remember, after today, if you have questions or you need other help, it could be your local PTA, it could be your staff in a clinical setting, it could be an individual. If you need help around training and education, you can put in a request to Opioid Response Network. Thanks so much, and we look forward to having you.
Thank you. Well, welcome everyone. What a great turnout for our first community event. We are thrilled to have so many people joining us today. About 450 people registered for this event. It shows the importance of this issue. And again, my name is Dr. Jose Vito. I will be moderating this event, and we have such great dynamic speakers from Dr. Kevin M. Gray, Dr. Alvaro Becerra Filho, Dr. Mario Renato Vellet, and Dr. Dhruti Patel. Our agenda for today, we will have our featured speaker, Dr. Gray. Then we will have a case presentation with Drs. Filho, Vellet, and Gray. And we will end with a Q&A with Drs. Patel, Dr. Filho, Vellet, and Gray. Just a quick housekeeping. Feel free to ask questions anytime during this presentation by clicking the Q&A tab in the lower portion of the control panel and type in your question. Again, just to be clear, this is the Q&A tab, not the chat tab for the questions. With that, I will turn this over to our first presenter, Dr. Gray.
Thank you so much, Dr. Vito. Much appreciated. And see if I have my advanced. Yay, it works. So really appreciate uh, the group that's on this Zoom, and appreciate the opportunity to speak. So I will confess, I'm in Charleston, South Carolina, where we're having Tropical Storm Debbie. So I'm not in my usual office area, but hopefully I'm transmitting okay. So I'm at the Medical University of South Carolina in the normally beautiful Charleston, South Carolina, but it is quite wet and rainy and soggy right now. And really, for our presentation today is I focus on adolescents and young adults in my practice and in my research portfolio, and really kind of want to step back a little bit and not dig too much into what's bad about adolescence, but actually really talk about what's exciting about adolescence as a developmental stage. So first, by way of disclosure, so my team conducts research that's supported by the National Institutes of Health. This is not going to be an in-depth research presentation. This is really designed to be something that hopefully will be helpful kind of across audience members, and from whatever perspective you come from. I think there's a lot of value from us at every perspective. I have provided consultation and received research support from pharmaceutical firms in helping to guide them toward additional treatments to help with addiction problems. So first thing is I will say is it's a phenomenon as old as time, is that adults complain about adolescence. I never thought I would have a Snuffy Smith comic strip on here, and probably people younger than I don't even know who Snuffy Smith is, but he's been on the comic book pages comic pages in newspaper for a long time. But I thought this was actually a recent one that was pretty poignant and really kind of showing is that how this is a long-term intergenerational issue of older folks not understanding younger folks. It's not a completely new phenomenon. And actually, I'll share this quote. Teenagers these days are out of control. They eat like pigs. They're disrespectful of adults. They interrupt and contradict their parents, and they terrorize their teachers. And of course, this could be a quote from today, maybe from a couple of decades ago, maybe even a century ago. The truth is, this actually is from the 4th century BC from Aristotle. So again, adults complaining about adolescence is a story as old as time, and something that we just want to think about actually flipping the script and reminding ourselves is that part of why people complain about adolescence is that adolescents are going through a lot of change, but this is really exciting change, and it sets so much the stage toward adulthood. And that's part of why it's such an interesting developmental state as a clinician, because it's always presenting new challenges, but also I will flip that and say new opportunities. Generally speaking, with adolescents, I don't think we need to review entirely, but broadly speaking, we think about age 10 to 14 as early adolescence, then to mid-adolescence, then even into young adulthood. And the more we understand about brain development is that really occurs even through the mid-20s. And so generally speaking, about age 10 to the early 20s is adolescence. And there's a lot of individual differences in terms of pacing, in terms of development. But as we think about a trajectory of growth, and this is a little bit math looking, but I promise to simplify it a bit. So x-axis is time, y-axis is growth. Usually when we have a developmental process, we imagine a linear progression toward the goal. But if we think about it, any real process has a lot of fits and starts and ups and downs and spikes and valleys, et cetera. And then some would say adolescence is actually more like this huge scribble between point A and point B. It's anything but a linear progression from childhood to adulthood. And part of that is actually owing to brain development in adolescence. And so this is a simplification, but I think an important illustration is that essentially we can think about different parts of the brain functioning as a gas pedal and a brake pedal. And during adolescence, we have this unique phase in which the gas pedal develops more robustly than the brake pedal does. And so you have essentially thinking about a car is it can go really fast, but it's not very efficient at stopping when it needs to. This helps to explain why adolescents engage in risky behavior, because they are more likely to make decisions, whether or not they're impulsive decisions, they'll make decisions that are more risky than other age groups will do compared to childhood and adulthood. And actually, if you think about it, it makes sense for adolescents to take risks because to develop independence, they do have to take chances and they do have to learn from mistakes. And that's something we can foster and facilitate rather than completely avoid. And it makes sense because adolescents they need to leave the nest. They need to establish their own peer group. They need to establish their pathway in life. And so this brain development actually is something that would be predicted just from our behavior over several generations. And I think about this too, is that, I'm engaged in research and we're really understanding cutting edge technology and how we're learning about brain development, but a lot of it really maps onto wisdom that we've known for several generations. And so the first is that adolescents absolutely need to assert their independence and work through failures along the way towards success. this is an inherently risky stage. And I think the real art of helping adolescents navigate this is setting a guardrail such that there's enough mitigation of extreme risk with real harm, but allowing enough risky behavior to learn from mistakes. And so we should all acknowledge that it's complex. One thing that adolescents will push very hard to avoid structure, and I think one thing that's really clear is that adolescents do need structure limits to varying degrees, and obviously this is a process where you modify that over time. Another thing that I think we don't imagine is happening as much as it is that adolescents are watching what they do, whether or not their eyes are rolling, whether or not they claim to be listening to you, they do hear you and they do see you. And a lot of what we do is set a model for them to strive toward in adulthood. And they're not going to tell you that they're looking at you, but they are. And I think that's an undersold area that we can do no matter who we are as an adult. And we can encourage and facilitate positive peer interactions. We know adolescents are going to be much more geared toward their peers, and a big predictor of their success in navigating this challenge of adolescence is having positive peers. And of course, we can reinforce success along the way. We usually notice adolescents when they're frustrating us and we behave accordingly, but we do also have to really reinforce and celebrate when they're successful along the way. And I will say this all to say also is I don't want to oversimplify. Tailoring is necessary. So not adolescents are the same. Some take more risks than others, some mature more earlier than others, and some are more prone to adverse outcomes than others. And this is even if you have the exact same environment, the same two parents, wildly different outcomes can happen. And I think that's part of what's wonderful about adolescence is that there's no two that are exactly alike, although some general guidance can be really helpful. So first, well, let's talk about challenges. What's old and what's new, right? So some of this is as old as time. Adolescents have a lot of challenges, but there are also some new things that we'll talk about as well. So the first, and I think what's relevant for what we do as a profession and many of those who are on this webinar is adolescence is the peak age of onset of most mental health and substance use disorders. As long as we've understood these disorders, we know that this is the peak age of onset. And so why I got into this is really trying to help adolescents be successful in optimizing their trajectory into adulthood. So a lot of this onset is related to the complex process of adolescent brain development. So there's a lot of vulnerability. So we know a bit about gene and environment interaction and how that can surface in adolescence. In adolescence, also, what is really interesting is that there's a lot of storm and stress in adolescence. And so there's behavioral and emotional vacillations that may or may not map onto a mental health disorder. And I want to be mindful of that too, so that we don't over-pathologize what might be normative adolescent struggles as they're working their way through this phase. So some of the new challenges. So obviously we know there's several recent societal changes that have really contributed to what has been characterized as an adolescent mental health crisis. The first development is actually a good one, I would say, genuinely speaking, is that destigmatization has occurred so much to the extent that adolescents now can put words to what they're struggling with and they can ask for help with what they're struggling with. It's a wonderful phenomenon that adolescents have this language, this ability to detect and also to be open about seeking out help. Now, of course, we're working on systems to better meet those needs. But it's not just this that's led to increased rates of mental health difficulties. And some of those are really difficult developments. One of those is pandemic-related social isolation and learning loss, which is something that I think the current generation of adolescents genuinely had a very different experience of a significant chunk of their adolescence based on isolation. Some navigated well, some have really struggled with it and have had a hard time catching back up thereafter. We've also done, even outside of the pandemic, we've done a lot of transitioning from in-person to online socialization. So the data are really clear on this, is that it's become more normative to interact online rather than in person with a lot of adolescents. And social media is its own difficult thing to navigate. And even at a parent level, it's difficult to know what to forbid versus what to allow and where to strike a balance and benefit and risk with that. And I think that really comes into another thing is that we have potentially reduced guardrails and a lot of sort of protective things in terms of cohesive community and structure. I think a lot of the phenomena that are happening have really atomized life for a lot of people. And I think sort of leaning back into the idea of how many built-in supports we have to help navigate with adolescence would be really helpful. So from challenges, let's go to solutions, right? And I'm at risk of being repetitious. I would say adolescents do benefit from structure and support. Don't be shy about that as a parent, as a community member, et cetera, is knowing that they can benefit from that because there's modeling and they also learn through the limits. And we can provide this individually and collectively. And this balance to strike is, on the one hand, the impulse might be to bubble wrap so your adolescent does not come into harm's way. I think when I say bubble wrap, everybody knows, well, I wouldn't do that, but sometimes we can be overprotective. But on the other hand, we ought not do free range adolescents and just send them out and hope everything goes okay. And so that's where sort of the tailoring goes into this. But we really need to pay attention, though, and take action when adolescents are struggling. So trying to allow for dialogue as clinicians, as parents, as peers, allow adolescents the room to talk about when they're struggling and then to help them out when that occurs. I would also say we can really turn the tables a bit and leverage some of the challenges as solutions. And so as much as I may complain about how social media and perpetually online adolescence that may be difficult, this connectivity also provides more connectivity to care and services. And so there's a lot of advances in terms of mobile technology delivered interventions, affiliative peers, those sorts of things can be very positive with destigmatization, advances in care via research. There's a lot more we can do that otherwise adolescents might have suffered quietly and not gotten access to care. So just as a reminder, as I'm wrapping up my talk, so adolescence is a critically important and exciting developmental stage. So the good news is rapid advances in science, teaching us a great deal about adolescent development. Clinical interventions are becoming more effective and readily available. And families and communities can really play a big part with some common sense approaches that are easy on the face of it, but sometimes can be challenging to deliver on. So we want to give them room to learn from mistakes, provide a strong model of healthy adulthood, facilitate positive peer interaction, set firm and appropriate limits, titrate as necessary, and know that the endpoint is letting go over time. And that's a good thing, as much as it can be hard as a parent to let go. A couple other reminders on this is that we won't get a thank you from an adolescent in real time, and that's okay, right? So the thanks come later when they have successes and they recognize they've navigated adolescence and that you may have helped. So, but the thank you is in seeing them developing well. And ultimately, I remind this, as much as sometimes things are in conflict, adolescents, parents, and communities want the same thing. They want an adolescent to grow into a healthy and successful adult. And I think we can all be reminded today's adolescents will be tomorrow's leaders. On the one hand, that may feel a little bit scary, but on the other hand, recall that Aristotle was complaining about teenagers in his time. Subsequent generations happen to do pretty well. So let's all invest in their success. I do have a resources page here, so if we're able to share this content, some of this is just really around youth mental health. The Surgeon General has really good guidance on this topic, and a few other resources here, both around mental illness and addiction. Also a plug for the Adolescent Brain Cognitive Development Study. My colleagues and I at MUSC are one of 21 sites around the country, 12,000 or so families participating in this really landmark study in terms of adolescent development that we're learning so much from. And also just bragging on the MUSC Youth Collaborative Team, where we're really doing a lot of work, multidisciplinary work around research, clinical care, and education, helping adolescents navigate this developmental stage. So appreciate your time, and we're going to jump from me onto the case presentation. Thank you.
Thank you so much, Dr. Gray. So we are now going to go on to the next segment, our case presentation.
Great. Thank you, Dr. Gray, and thanks for helping us conceptualize the mental health and substance use challenges that adolescents can have. So I'm Dr. Blee. I'll be presenting alongside Dr. Teixeira a case presentation that's going to help serve sort of as a framework so that we can build potential questions that we could have. And I hope you maybe spark some questions for the chat. Next slide, please. So our case is an adolescent, Billy, 17 years old, who's started to maybe change a little bit of his behavior. So he's been complaining of headaches, and he says that his heart starts racing at school uncontrollably. He, missed school because of these problems that he's having, and this led his mother to become concerned and take him to the emergency department. Billy explains to his mother that, that she's noticed alongside with his friends, family, and teachers that he's been moodier and more irritable both at home and at school. Teachers have noticed maybe he's falling asleep in class, and that many nights mother has noticed that he's been staying up past his bedtime because he can't fall asleep. Next slide, please. So the mother and Billy go to the ED, and the nurse uses a survey to try to get Billy to talk about his problems. Any changes in behavior should, we just do a sort of a screening for substance use disorders. It'd be a good idea to do that. Because of Billy's mood changes and his issues with sleep, the emergency physician ordered lab tests, urine drug testing, and other blood tests as well. Next, please. So the doctor spoke with Billy and his mother, and some of the symptoms he's been endorsing are feeling less motivated, very tired, losing interest in things that he used to enjoy, and feeling anxious. And it's hard to pinpoint, what the cause of this is. The mother agreed that she's noticed some changes in the past few weeks, and it's hard for him to talk about it. She doesn't know how to address them. She noticed his mood, worsened over time, and she thought that some of the sadness that he had when he was around 14, could have maybe improved, and maybe it was just hormonal changes, maybe it was just a phase. Billy seemed reserved around his mother, so he had difficulties explaining what was happening. During a private conversation with the doctor, Billy revealed that he had some experiences in the past and had been using substances like cannabis, alcohol, potentially LSD to cope with his feelings. He endorsed that he used the substances several times a week and felt uncomfortable being sober. Billy appreciated his mother's support, but she was unaware of his substance use. A lot of times in adolescence, it's typically the age where, as Dr. Gray said, it's the age where substance use can start. And although some adolescents can start, it doesn't mean everyone becomes addicted. In fact, most youth don't become addicted. But it's something we have to screen for co-occurring mental health problems and other reasons as to why someone could start substance use. Next slide, please. So Billy starts breaking down, what sort of happened and how he started using substances. So at age 14, he started using cannabis to cope with feelings of sadness, anxiety. He tried it initially due to peer pressure, but then it helped him with his emotional distress, so he continued. By age 15, he was drinking alcohol, which helped ease anxiety and depression. And as he continued using it, he realized that it continued helping and he needed potentially more. This escalated to binge drinking, which further complicated emotional well-being. And at age 16, he tried LSD at a music festival. He found that it helped, created a detachment from reality, which led to eventual regular use. And by 17, he was using the substances several times a week and felt uncomfortable being sober. So some of the, he was coping with the substances, but also with regular use, there could be other symptoms that provoked or allowed the continuation of the use. Next slide, please. So now we have a little more understanding about him, and we sort of have to get to an assessment and determine how we engage Billy. So we try to determine, how serious the substance use is, and we have to evaluate different areas, including what risks of intoxication and overdose do they have? Do they have other mental health problems, which might lead to an increased suicide risk or violence risk? Potential medical complications from the substance use, and then other social and environmental safety concerns. And it's important to bring the family in as well to develop a supportive and more effective therapeutic relationship. Next, please. And so while waiting for the test results, Billy felt more comfortable sharing with his mother what they had discussed in regards to the substance use. When the labs came back, the urine was only positive for cannabis. Everything else was negative. Billy's mother felt a mix of emotions, and it's something they could potentially blame themselves. They could feel shock, disappointment, anger, confusion, unsure how to handle the situation. The treatment team explained to Billy's mother the issue was complex and the substance use was linked to underlying mental health problems, in this case, trauma that Billy had in the past. And so, this was one of the reasons why Billy had been using substances to manage his anxiety and depressed thoughts. Next slide, please. So finally, the case had been clarified a little more, and we developed, a treatment plan. And it isn't just medications, we're clinicians. It also includes counseling and therapy potentially. So there's not just one way to treatment. It has to be tailored to the patient. And so there's an acute and long-term management. So now I'm gonna hand it off to Dr. Teixeira to continue with the acute management of the case.
Thank you, Dr. Velit. So I'm Dr. Teixeira, and I want to move on to the second part of our case presentation and move forward on our discussion. We'll talk about priorities, especially in the acute setting. So first and foremost, of course, we need to stabilize any medical complications like intoxication or withdrawal. We must keep the patient safe. Next, we check for, deal with and manage any mental health issues like depression or anxiety, because, oftentimes they accompany substance use. Family involvement is also crucial. So we bring in the family and we educate, we teach them about substance problems and also things that they can do to help. Another powerful tool that we have is called motivational interviewing, which is basically, a way to boost the adolescent motivation for change. And in this case, is for, harmful behaviors like substance use. Next, we help and guide the adolescent through the right kind of treatment for them, like seeing a counselor, for instance, or seeing a treatment center, residential program. We have to ensure regular follow-up visits, both for, checking about the progress that has been made, but also to tackle any challenges that may appear during the treatment phase. And, these acute management is sort of like builds the foundation for us to transition to the next phase of treatment, which is the long-term care. So in this phase, we set up a multidisciplinary team. We bring in, psychologists, psychiatrists, social workers, primary care physicians all together. Therapy is also very important, and we have options such as family-based therapy and cognitive behavioral therapy. Counseling can be done not only in the individual setting, but also in family and group setting as well. We help the adolescents set up achievable goals and also monitor their progress. Medication is also very important, and especially when there is substance use along with mental health issues. And as I said, they oftentimes accompany each other. In terms of continuing care and support, there's education. Some, adolescents, they might see themselves going from, top of their classes to struggling with their performance. Others, they struggle with school failure, dropping out, not showing up in school, and while others have some learning disabilities, so focusing on education is very important. Also, employment and vocational services. Studies have shown that adolescents that have held jobs before or are employed during the treatment, they usually have better outcomes. Finally, culturally based programs, which is basically a way to, integrate the adolescent's cultural background into treatment. Now, let's shift our focus to the barriers to treatment that might appear. So adolescents might feel invincible. They might feel like nothing's bad is ever going to happen to them. They might struggle with immaturity. They, after all, their, brain's not fully developed yet, and they might not see the future consequences of harmful behaviors, substance use, for instance. They might have mixed feelings, and they might be ambivalent about treatment itself. They might feel overwhelmed about, even the prospect of treatment. They might have pushback against parental dependence. They might feel like they can handle everything on their own. And of course, stigma also plays a big role here. Fear of judgment can, keep people away from treatment. Now let's go back to the case presentation. During the same visit, Billy received the medication to help him with his mood and anxiety symptoms. The doctors understood that he had been self-medicating, so they offered him medication, specific medication that would help him with this. Specifically, medication, a type of antidepressant, medication from a class of selective serotonin reuptake inhibitors, the famous SSRIs. And they emphasize that these medications, they work very differently from the intoxicating substances that Billy had been using, which offer, immediate but very brief, very temporary relief. These SSRIs do not produce instant effects. However, their consistent use can lead to significant and long-term improvements. And of course, the family felt a mix of emotions, right? Shame, sadness, confusion, anger. They wondered why Billy didn't talk to them first, and they felt unsure about how to react. Whether to scold or comfort him, monitor his every move at home, talk to his school, set limits. The doctor reassured their feelings, says, their emotions, after all, are very common, and it's actually a normal response to parents. They suggested that they talk openly with Billy, set up clear rules, while also trying to trust him. The doctor reassured the family that they're not alone, and there are resources available to support them. For instance, family-based therapy, which is a type of therapy that involves parents, caregivers, and siblings. Before leaving the hospital, Billy expressed a desire to stop his, substance use and was willing to join a program that could help him with this. He had appointments set up with mental health professionals to continue therapy and counseling for his substance use as well. And his family felt encouraged and supported, seeking to understand and navigate the situation with a mix of hope and determination. So in summary, I think that the big take-home point from the case presentation is that there are proven psychosocial interventions, especially the ones involving family, that, along with addressing any co-occurring mental health issues that often accompany substance use, these form the cornerstone of treating adolescent substance use disorders. Now I'm gonna pass on to Dr. Vito, our moderator.
Okay, no, that's me. Thank you so much. Just a quick reminder, we are having our event, a free in-person community event titled Navigating Adolescent Development, a community session with psychiatrists on Sunday, November 17th from 9:30 to 11:30 a.m. at Naples Grand Beach Resort, 475 Seagrave Drive. This is a start, triple AP. Hope to start doing this type of events in our annual meeting in our local area. ORN will also be there. They will have a booth and they will have a local resources. And let us also know how we're doing with our presentation. So you have a link for the survey as well. So with that note, we're going to start the Q&A. And I'm going to leave the slide here at the top, on the front. So we're going to start with the Q&A. The first question is for Dr. Patel. The question is kind of long. So it says, how do socioeconomic and cultural factors influence youth substance use, and what targeted approaches can be developed to address the specific challenges in diverse populations?
Yeah, thank you for this question, and thank you to all of our speakers today for this wonderful presentation. Really happy to have this outreach started, and looking forward to see where this continues to grow. But kind of focusing on the question about the socioeconomic and cultural factors, I mean, these are really significantly going to be influencing the youth substance use. Adolescents coming from a lower socioeconomic background are going to be facing higher levels of stress due to financial instability or limited access to like recreational resources or even mental health services. And so this can increase the risk of the youth resorting to substances as a coping mechanism. The other thing to keep in mind is that cultural norms and attitudes to substance use itself can play a critical role. So some communities either stigmatize or normalize substance use behavior. So it's really important to identify, where this youth is coming from and what the cultural norms are in that community. So it can help guide you in terms of better screening and better approaches to these behaviors. And so kind of going in this, there are many, much more depth to this question that I think will be nice to keep developing, but kind of focusing on targeted approaches to addressing some of these challenges. I think someone had asked about what resources are available for even Spanish-speaking patients and how to educate families and of youth that are using substances. I think the first is to start with a community-based prevention program, and this can incorporate community leaders or different people that have a better awareness of the culture in that community, so they can be more sensitive and tailor to the unique needs of this diverse population. And so really involving important members of the community into this treatment model and engaging and designing programs that hire staffs that incorporate the community and reflect their values. That could be a good place to start. And moving from there, having access to more affordable not only mental health services, but even education enhancing resources, whether it be on the school level or in the community level, and creating safe, drug-free recreational spaces. I think that can help mitigate some of the socioeconomic and cultural influences that really target some of these youth that resort to using substances. So that can be where the schools and community organizations can play a pivotal role in offering these initiations of safe recreational spaces, and in that targeting different educational models that can decrease the risk of use and promote healthy coping strategies.
Well, thank you, Dr. Patel, and also including about resources. On that note, the next question on the Q&A, and is open for everyone. Any specific therapeutic approaches to managing substance use disorder in adolescents for those of you who practice in rural area? SSRI, of course, for depression, anxiety is appropriate, but specific therapy, first aid we can use at the PCPs, any med management advice? Thanks.
So certainly I recognize PCPs in particular. I know y'all are tasked with being jacks of all trades, especially in rural areas where being able to refer out is limited. So I appreciate your willingness to really tackle these very challenging issues, and also realize even that you're open to the idea of how could I engage in some limited form of psychotherapy or a certain approach with this. So I guess the spirit of this, of what I would say, is that part of it is family involvement of any kind can be helpful, so long as it's really around trying to support positive outcomes. And with the individual aspect of it, when you're in the office with a patient, two approaches generally stand above the rest in terms of the individual interactions. And one of those is motivational interviewing, which is more a spirit than a scripted kind of psychosocial intervention. It's really around meeting a client or patient where they are and gently nudging them toward behavior change in such a way that it's non-confrontational, but there's a spirit in terms of, I think, the most common presentation of an adolescent where there's an issue with substance use is because someone else considers there to be a problem, and the adolescent may or may not recognize it themselves. And you're in a tough position as a provider. And the last thing you want to do if you want to create any kind of therapeutic alliance is to be confrontational out of the gate or to make assumptions out of the gate. And so part of it is really around is thinking about, I'm here to learn what this presentation is, understand the context, and work from there. So the tailoring, sort of showing some respect about, I want to understand how you're presenting, and trying to work toward gradual change rather than confrontational, because you wind up with better long-term gains that way. So it's sort of a spirit rather than having to be scripted with this. And then in terms of the modality and in terms of behavior change beyond that approach is cognitive behavioral therapy, which the good news is it can be used and tailored across a lot of conditions that adolescents present with, and it's very practical. And a lot of it can really be around some very practical things about, if you're in a social gathering where people are using, how do you navigate that? Do you need to avoid entirely? Are there some strategies you can do that you can decline substances. And so some very practical things in terms of the idea, if you're at a gathering, at a wedding reception, and people are going to offer you drinks, always have a full drink in your hand. And so you can always say, I'm good. Practical like that. But then when it gets into comorbid depression, anxiety, and substance use, is really working on establishing some cognitive coping mechanisms, especially when somebody's driven to use because of their craving, because they're anxious, they're craving because they're depressed. And so part of that is helping them to practice those skills. It's first giving them confidence that they actually have the power in their brain for a lot of this, but it's a lot of skill practicing with that too. And so on the fly in a primary care setting, I know there's limitations in face time with this, but generally speaking, it's really around tailoring and understanding the context as best you can. You're never wrong to employ motivational interviewing as a tool. And I think sprinkling in, even if you're doing medication management, sprinkling in some cognitive behavioral interventions can be really helpful. So, and I realized the question was also around med management, which I don't want to take the floor too long, but if anybody else wanted to speak a little bit more to that, we're doing a lot of work in terms of clinical trials for medications for substance use disorders in particular, but I would drone on for too long about that. So I'll be quiet and let others speak up.
Yeah, no, I'll just piggyback off what you were saying, Dr. Gray. And, in terms of the med management approach, I think we're still too early in identifying true medication that can be useful for youth with substance use disorder. Right now, we're limited about what's FDA approved for youth. And right now we're only limited to medications for opiate use disorder, being more of the Suboxone being that's FDA approved for youth with opiate use disorder. But with the other substances, we're really limited in terms of what medications that we can offer. So, I do emphasize early screening interventions can even avoid maybe a progression of the use, and cognitive behavioral therapy can help limit and reduce the use before it gets to the point that they need medication-assisted treatment. And so identifying anxiety, depression, any other mood disorders or ADHD, this is really crucial to screen and treat before we can then say, now we need a medication for the substance use disorder, because we are very limited at this point. And I hope that further research will answer some of those questions.
Great, thank you so much. Our next question is for Dr. Philo. Do professionals notice any greater use of substance use disorder in a non-traditional homes, being raised by a grandparent or those in foster care? Also, what should, for example, parents do if they suspect their child is involved with alcohol or drugs?
Yeah, I think those are, very important questions. I think that, for the first part, I think that anecdotally speaking, some non-traditional homes, as it was mentioned, like grandparents or foster care, they may have some, higher risk of substance use. And, there's some risk factors that you have to understand when it comes to this question. First one is trauma and, some adverse childhood experiences. Because, adolescents in some of the settings, they, oftentimes they had higher rates of trauma and adverse experiences, and these can contribute to the development of substance use. Also, psychosocial stressors, for instance, like instability, frequent relocations, and, even disruptions in their social network for any reason can also increase the vulnerability of the adolescents. Attachment issues as well, can be an important risk factor for the adolescents, and they might use, the substance as a way to cope with the stress, for instance. And, about the second part of the question, what should, parents do if they feel like their child is involved with, alcohol or drugs? Well, I think that, one of the most important parts to have open conversations, have clear communication. And if you're lucky enough to have, these conversations early on before it even becomes a problem, or if any use begins, it can maybe deter them from using. And if you already suspect or that your child has experimented, it's important to approach the situation with curiosity and care, and, ask them about about their experience. Try to get like a glimpse of what was the root cause. of their behavior, what drives their behavior. Because oftentimes, as I mentioned, teenagers, they use substances as a way to cope with stress. So they might say, hey, I was feeling, stressed out, so I use alcohol to feel better, for instance. So clear communication is key, but also, as Dr. Gray mentioned in the presentation, sort of like provide a guardrail and modeling of adult maturity, explain like your views, your values, your concerns about substance use as well, and make it clear that you're there to support them. You might say, for instance, I know there's a problem. I want you to know that you can rely on me and trust me about it, for instance.
Great, thank you. So communication is definitely key. Just a reminder, please send your questions to the Q&A section, not in the chat. But what I'm seeing on the chat is our audience really wants to know substances are more commonly used by teenagers today. This question is for Dr. Vellet.
Sure. So what substances are more commonly used by teenagers today? There's three that seem to be more used: alcohol, marijuana or cannabis, and nicotine. So I believe previously, like, cigarettes used to be used more, but now they're falling out of favor in kids are preferring e-cigarettes. And this is actually an escalating number. And generally speaking, substance use is more initiated during adolescence. So it's something, we got to watch out for. Alcohol is still, the most used. It's about something around, studies suggest that maybe 64% of adolescents have used alcohol at some point. Once again, using it doesn't translate to it becoming a problem. It does expose an adolescent to higher risk for a substance use disorder. With the likely, if you drink before age 15, there's up to 6 times more risk for alcohol dependence than those that wait up until they're 21, for example. But it's common that substances are started during adolescence. So alcohol, something like 64% of adolescents have tried it. Cannabis or marijuana, about 45%, and then nicotine through the vapes or e-cigarettes, somewhere around 31%. It's important to note that there's other reasons as to why somebody might start using substances, as Alvaro had also been mentioning, family, social, individual risk factors, things that we take into consideration as well. Other drugs are less common. So maybe, outside of alcohol, marijuana, and nicotine, maybe 6% of, report some other substance use. And so it's important to try and delay substance use as much as we can.
Yeah, and I'll just great summary, and I'll agree. And so part of our mantra is really, a lot of parents get stuck in the trap of saying, well, am I saying do as I say, not as I do? Say, if I drink socially, the first is really trying to model that you're not drinking to cope. I know sometimes people fall in the trap of, they get home from work after a stressful day and, oh, I really need a drink. We want to try to avoid that kind of labeling of reasons for using, but you can also establish a model in terms of just general responsibility that can include attitudes about substance use. But really, the more we understand about adolescent development, the more clear it is the longer that you delay, the much lower the risk of a use disorder or subsequent mental health consequences of your use. And so there's a lot of data around adolescent onset cannabis use and its association with psychotic disorders. And we know the longer you delay cannabis use, you mitigate that risk. And similarly with substance use disorders. And I would say is one of the things that we really look for in clinicians is reasons for use. And, we're seeing a lot more, and this predicts adverse consequences, is using to cope with negative emotions is a predictor of a use disorder. And so if you see adolescents going from, oh, I'm using socially because my friends are using, while that certainly is not entirely safe, it becomes more concerning when it started with that and then it progresses to, well, I'm using in the morning so I can cope with my anxiety at school the next, later in the day. Those are the sorts of things that suggest more intervention might be necessary. So the first tactic is really around prevention that starts early, and we want to delay as much as we can. But once it's started, all hope is not lost. And even in substance use disorder territory, this is what we've focused our careers on, is really working with young people and trying to mitigate those longer term risks. And so much of this is navigable. And I think what it really comes back to is really understanding that individual presentation and addressing accordingly, and knowing that even so those substances like opioids are relatively rare, thankfully, with adolescents. They have really serious implication, which is part of why we're really focused on having the best possible care, because there's a lot of adverse consequences associated with adolescent onset opioid use.
Right. Along on that line, there's questions about fentanyl, youth who are using fentanyl. What do you guys know, or what do you see in your practice, or any data, including relapse or recovery about youth and fentanyl?
So, I mean, I can mention quickly is that the range of fentanyl use is pretty broad. So I think all of us are attuned to the risk with fentanyl is the window of dosing between what someone might consider desired effect versus a potentially fatal overdose is very narrow. A lot of times when adolescents access fentanyl, it may not be knowingly so. And so oftentimes when we see an opioid overdose owing to fentanyl, it may not have even been intentionally ingesting fentanyl, but it may have been an adulterant in another product they were using. So that's an important thing to understand in the emergency setting, is what the reasons for use might have been and whether they had known about that. But I'll let others chime in on this one too. Certainly it raises the stakes in terms of just how potentially dangerous even a first exposure to fentanyl might be.
Yeah, definitely. And I don't particularly work directly with youths. I don't have that exact number in terms of data giving idea of, how many stay in treatment and what the outcomes look like. But when we do see them coming into our hospital for, let's say, detox or early kind of treatment programs, when they are usually in their at that point 18 and above stage, we do see them starting at a young age. And so at this point, it is really important to either prevent or engage them into treatment or offer them medications that can help them with their opiate use. And I know someone asked about what is the best way of connecting these youths to prescribers for medication and identifying where they are in terms of the severity of their opiate use, and whether it can be managed with behavioral interventions, or given this, if it's much more severe in nature, then it may require medications to help manage cravings and maintain a level of recovery. And that's when it requires prescribers to feel comfortable prescribing Suboxone or other medications. And this can be done by any provider on this level. It's not limited to now addiction psychiatrists or anyone that's done the waiver training, and it can be done by a PCP or a psychiatrist that can feel comfortable monitoring and managing this patient, this youth on Suboxone for maintenance, if it comes to that point.
Yeah, thank you for that. And someone put on the chat, in their program, they actually have 80% relapse rate for fentanyl users, and they're only working with 10 to 17 years old. So thank you, Dr. Patel, for your answer. Now, this next question, this is for everyone, and it's kind of a long question here. So bear with me. It's from an anonymous attendee. So this person works in a high school, and they're facing a lot of common smoking and vaping use. Many members of our community use marijuana recreationally and for self-medication purposes, including many of our parents and families. Students are coming in lethargic, tired, and unable to focus in classroom. They are also more willing to experiment with their other substances and consider marijuana as a commonplace. Do you have any suggestion for community intervention on the school and or community level?
I think starting with education, it seems like, if there's a culture of use, and they're not, maybe like the family isn't aware of potentially, the harms that could be happening, the excessive sleep at school, or even just suggesting that, early use is okay. It might be valuable to, as kind of what we're doing now, sort of address the community and to bring them into the conversation about substance use and the risks and benefits. And in the spirit of MI, sort of just gently, showing them the evidence and nudging them towards, hey, like maybe this is, what you see, what your kids are seeing isn't going to be, I mean, it might be replicated. And if it is replicated, there's these risks. It's just so generally, like rounding it out, it's, I think, education and involving the family.
So on that note, Dr. Philo, are there any early warning signs that parents should look for?
Yeah, I think that it's a very good question. I think that the key is any kind of like changes in the adolescent's behavior, any change in their baseline at all. I mean, the parents are like the experts about their children. So if they notice any change in like mood, the adolescent may become like with a lot of moodiness, get into fights, associating with friends who maybe get into trouble, along with other signs, maybe like their school performance is worsening, they're cutting classes, dropping out, not doing activities that they previously enjoyed, or like getting to more arguments. Those are like indirect signs, right? Now, there are more direct signs that parents might notice, like, unexpected over-the-counter medications at home, missing pills, or like finding, cigarettes or like rolling paper in the house, or like smells of alcohol or smoke. And, this coupled with noticing that the adolescent's not acting like themselves is like a good sign to invite them for conversation. As I said before, clear communication is key, and open conversation. By doing that, you're almost like opening the door, saying that, I'm interested, I'm curious about you, and I care about you.
Great. We have another great question here. Please differentiate between the use of substance and substance use disorder. The use in adolescent has root causes not yet diagnosed in too many cases. So this is a good question.
That is a good question. I mean, I think it kind of goes back to understanding kind of the difference between substance use, which is, with youth, it could mean early experimentation and, with especially peer pressure, and depending on what community they're in, they could have what's called substance use. And if it continues to progress, could turn into high-risk substance use, where now they're, engaging in maybe abusing prescription pain pills, or going into more of the other types of drugs like heroin or fentanyl. And that's when it becomes high risk substance use. When it becomes a substance use disorder, is now it's affecting their level of functioning in some capacity. And we kind of range it from mild, moderate, or severe. And that's where it is really important to understand the difference between using versus kind of becoming a use disorder, where they have developed more of a dependence or tolerance, and now it's affecting their day-to-day functioning, their emotional range and capacity, and causing more problematic behavior in their life. And want to catch it at more of that early stage before it develops into a substance use disorder. And Dr. Willie had maybe something to say. I interrupted him.
No. I think you ran that well. Thank you.
Great. Thank you so much for our great panel of speakers. And this, unfortunately, is the time where we have to say, we have to end the program. Again, a quick reminder that we will be having a community event free in person in Naples, Florida on Sunday, November 17th. And also, we would like to thank AAAP and the Opioid Response Network for co-sponsoring this event. Thank you so much, everyone. Take care.